Hey, good afternoon, everyone, and thank you for joining us at the Bewell Texas Systems and Sustainability Echo. My name is Andrea Roche. I'll be facilitating our discussion today. I see a few more people coming in, so I'll take a little bit with my housekeeping. Just a few announcements before we get started. As you saw just a moment ago, we are recording these sessions for later distribution through the Bewell Texas YouTube channel. Any information you share in the chat is not going to be shared on those recordings. Just to get us started, I do have a few little announcements. Please stay muted unless you're speaking, and we do encourage everyone to speak today. Please keep your comments brief, though, to allow space for others to speak as well. If you've joined by computer, your mute button is on the bottom left of your Zoom controls. If you're on the phone, just press *6 and wait for the announcement telling you you are unmuted. We encourage everyone to join by video, especially for the discussion portion of the session. But that said, we're happy you're here regardless of how you've joined. Please share your perspective today in our conversation and our discussions. You can do that however you like. You can use the chat to share questions or your experience, or like I mentioned before, you can unmute. If there are a lot of people talking at once, you might want to use the raise hand feature over in your reactions menu in Zoom. But please do note that no protected health information is allowed either in the chat or in our discussions. To help us with attendance, please enter your name, your affiliation, and your email into the chat function, which you can access at the bottom of your Zoom window. If you've joined by phone only, though, please do send an email to the Bewell Texas team to let them know that you've attended today's session. And just because that's so important, I do want to reiterate to all the Bewell Texas providers, make sure you've identified yourselves during this session. And if you're joining via phone, again, make sure to email your phone number to the Bewell Texas team. We'll pop that email over in the chat in just a moment. Towards the end of the session, the Bewell Texas team is going to send out a link to an evaluation survey, and we ask that you fill this out for a couple of reasons. First, it gives us some feedback on how to shape this programming to better suit your priorities and your needs. And also, all participants filling out the survey are automatically entered for to win a $30 Walmart gift card. Enter it into a drawing, excuse me. So today's didactic is going to discuss strategies for dismantling the stigma of substance use disorders. And following that, we're going to hear a case presented by Daniel Lavin. We're going to start our session with some introductions of the Hub team, followed by those didactics I mentioned earlier, some announcements from the Bewell Texas team, the case presentation, and then open discussion with all of you. So thanks again for joining us at today's Echo. Remember, these are a space for all of us to teach and all of us to learn. So in that spirit, we encourage all of you to share your experiences, your challenges, your questions, and your insight into today's conversation. So let's do some introductions, starting with Leslie.
Hi, everybody. I'm Leslie Manson. I'm one of the Hub team members, and my history is in integrated care, and that's predominantly in primary care centers, also providing behavioral health and substance use and treatment support as well. I do a lot of practice transformation here in the United States and in Canada, a lot related to integrated care sites, and I'm happy to be here.
Thank you, Leslie. Kathy.
Hello, everybody. I too am an integrated care program builder. And I'm a licensed marriage and family therapist, licensed professional counselor. Spent a lot of my time building and transforming practices for behavioral health integration across all types of healthcare settings, but also focused a lot on SUD services and the infrastructure needed both in the community and within facilities. Thank you.
Thank you, Kathy. B.
Hello, good afternoon, everyone. My name is B, or Briseda Coutois, and I am part of the Bewell Texas team. I am one of the program managers. I have been in the field of behavioral health services, prevention, intervention, such services, HIV, behavioral health for about 28 years now, and I'm happy to be here. Thank you.
Thank you, B. Matt.
Hi, folks. I'm Matt Rosa. It's good to be with you. My background's in clinical social work, former clinician therapist in private practice, and also agency administration, and a good bit of time doing governmental planning. I work now full-time as a consultant and spend my time mostly doing quality process improvement, a lot of NITEX rapid cycle change work, as well as a lot of implementation science for organizations and for research studies. Good to be with you.
Thank you, Matt. Adrian.
Hi, everyone. I think I've met many of you at this point, either in this program or our other ECHO programs. I direct our Center for Substance Use Training and Telementoring, or CSTAT, which oversees all of our ECHO programs. Like my colleagues, my background's in integrated care, and I'm clinically trained, but most of my work has been in workforce development and kind of trying to move evidence-based practices forward. Thanks for being here.
Thank you. Andrea.
Hello, my name is Andrea Hambler, and I am a project coordinator for ECHO for the CSTAT Institute. Thank you.
Thank you, Andrea. And Daniel.
All right, good afternoon, everybody. My name is Daniel Abbott. I'm an addiction psychiatrist at Baylor Scott and White Health. I'll be talking with you a little bit more later on today. Relatively new to this initiative, so it's good to see everybody's face, and hoping to get quite a bit out of it.
Great. Thank you for joining us. And then last but not least, our didactics presenter for today, Alanna.
Hey there, everyone. Good afternoon. My name is Alanna Boulton. I am a health system science program manager at Dell Medical School at the University of Texas at Austin. And in that role, I have the pleasure of leading all of our hospital-based addiction treatment work, which started very much so focused on buprenorphine administration for patients with opioid use disorder, but over the last 2 to 3 years has really expanded to other medications for opioid use disorder, alcohol use disorder, and working on some stimulant use work too. So excited to be here and to share some of our learnings over the last couple of years.
That's a great segue to our next part. Alanna, when you're ready, go on and share those didactics and take it away. And while she's doing that, just a reminder for those of you who joined, please enter your information into the chat, your name, email, and affiliation.
All right, are we able to see the slides?
Looks great.
Perfect. And it's like how many years of doing Zoom now, but just still want to make sure it works how it's supposed to. So as I said, I'm a program manager at Dell Medical School, but I've spent quite a bit of my career in program planning and implementation for inpatient and outpatient substance use treatment, a lot of it focused on opioid use disorder. So today, much of what we talk about may have kind of an overarching lens of opioid use disorder and inpatient treatment, but a lot of it is relevant and scalable to other use disorders and other care settings. So please don't take too much away from the title of our program or any of our kind of opioid-based discussion today. First off, no disclosures, no financial interests to report. We're talking about stigma today. And we'll talk about why we're talking about stigma later, but we're over the next 20 minutes or so, we'll talk about the way that stigma influences the way that patients experience healthcare delivery, both for their substance use and for other acute or outpatient primary care health needs. We'll talk about how institutional stigma reduces access for people who use drugs. Again, that could be for treatment for their substance use disorder or for just any other healthcare access that they have. And then the biggest takeaway from today is identifying ways to reduce and eliminate stigma in whatever practice setting you have. Again, a lot of what we talk about will be from the hospital setting, but it's definitely transferable to other settings as well. To set the stage a little bit, we're going to kind of go back in time. This chart is a little bit outdated. It's from 2017, but I continue to include it in these talks that I give because it does a really good job of comparing the number of overdose deaths that were reported in 2017 to the numbers of the height of the gun violence epidemic and HIV epidemic in the 90s, which were the public health crises of their time. And so even back in 2017, we can see that the numbers for drug overdoses far surpassed those, even this is almost 5 years now at this point. To fast forward a little bit, if we talk about the end of 2019 and the beginning of 2020, which is again a little bit outdated, we can see that even before COVID hit, we were seeing increases in the number of reported drug-related deaths or overdoses. The top stat here on this chart is Delaware, which is an increase of 60%. I'm not sure how large that is on your screens, but there are definitely local and regional areas that saw much higher numbers, a larger percentage of increases. Some rural areas in Alaska saw as close to 100% increase in reported drug overdose deaths. And again, the reason I include this slide is because this is before COVID. This is before COVID happened and our entire healthcare system got turned on its ear. So this was already an issue. We were already watching this. We were already seeing these numbers increase even before COVID. And then COVID happened. So this is a screenshot of a CDC health advisory alert that was released at the end of 2020 that the CDC released. They've only done a handful of these. And at the time, they were reporting something like 81,000 overdose deaths at the time. For the previous 12-month period, which if you think back to that first slide that we looked at, that was like a 70,000 number, and now we're talking about an 80,000 number. So about 10,000 more reported overdose deaths by the end of 2020, even in the context of COVID, right? So that's what this alert is about, is the fact that the social isolation and all of the kind of societal stressors that came with COVID, we all knew that it was going to really drastically impact substance use, which was then going to result in more unintentional overdoses. More recently, in April 2021, the Washington Post released these numbers, something like an increase of like 28, almost 30%. And you can see that top number in the top right is the first time that we had a reported number over 100,000 of overdose deaths. So at the time, this was the highest number ever reported. It was the first time it had passed 100,000 deaths of reported drug overdoses. And while all drug overdose deaths are concerning, what you can see is that opioids are responsible for essentially 75% of those deaths. Synthetic opioids, fentanyl, is obviously a specific concern. That's quite a big proportion of those overdose deaths that are reported. So just as time goes on, these numbers just get higher and higher and higher, right? We don't yet have final data for the end of 2021, but we do have provisional numbers, and the CDC is estimating something like 107, 108, maybe as close to 110,000 deaths. And those again are reported overdose deaths. So we assume that those numbers are underreported, that they're not categorized correctly, that number is probably much higher in real life. And then we're actually getting pretty close to the end of 2022 now at this point. We, again, don't have any data. We have some provisional numbers, but I mean, if you trend that over time, right, those numbers are just going to keep going up. More people are going to die. More people are going to have unintentional drug overdoses. So that's why we're talking about this today. So our first takeaway, the reason we're having this conversation is that people are dying, and they're dying at historic rates. Again, the numbers are just continuing to increase. Most of the people on this call are probably already aware of that, or you're already fully on board. But it's important to kind of keep this in mind as this tone setter for these conversations, and as you take these conversations back into your institution and talk to your leadership or your clinical teams. But why? Why is this happening? So we've been tracking this data for years. We know it's getting worse. There's a lot of people are talking about it. There's a lot of dollars out there floating around for interventions, prevention work. Why? Why are the numbers continuing to increase? Why are they going up? Why aren't they going down? Or aren't they stopping at least? These are some of the reasons we often talk about as being barriers to patients accessing and continuing treatment for their substance use or their addiction, or entering recovery. Lots and lots here, right? And this list could go on, and we could probably pull the audience and come up with 50 more reasons that people aren't able to access care for their addiction treatment. But at the end of the day, if you trace it all back, right, if you do a root cause analysis for all of these things, the main answer is stigma, is that the stigma of drugs, of people who use drugs, of addiction, is preventing people from accessing the care that they need to get healthy. There's multiple kinds of stigma. There's structural stigma, social stigma, and self-stigma. They're all very important. They all play really interesting roles in kind of the perpetuation of the addiction cycle. But today we're going to talk mostly about structural stigma and the way that structural stigma within your institutions or your care setting, your practice settings, and then the larger political environment that we are in, how that structural stigma impacts the way that patients receive care. But I definitely don't want to discount that social stigma and self-stigma are super important. They're really important things to dig into. It's just not quite the setting for this conversation today. And then this graph here is the cycle of self-stigma that's just self-perpetuating. So these are the kind of thought processes that people go through when they are being stigmatized for anything. In the context of this discussion, it's for substance use. So really important to keep those in mind as well, but we're going to focus on structural stigma for most of our conversation today. So what do we, the royal we, right? What do we think about people who use drugs, about substance use, about addiction in general? So the general population and the general population of healthcare professionals generally see substance use as being intimately linked to other highly stigmatized diseases or states. So HIV, Hep C, driving under the influence, all of that, like those intimately linked, all things that have a very negative connotation in the public eye, public perception. There was a survey of 1,000 adults, and 75% of those people felt that the people themselves, the patients, were to blame for their substance use. And unfortunately, that number carries over into healthcare professionals, specifically practicing healthcare clinicians. It's even higher. It's something like 80% of individuals polled thought that addiction should be criminalized and it was the person's fault that they're in this state in the first place. And then there's, some terminology that are often thrown around or often associated with people who use drugs or who have addiction or who are struggling with substance use. So reckless, unreliable, undeserving, threatening, scary, hopeless, worthy of their blame. Again, these are just the perceptions that are out there. This is kind of the intersection of structural and social stigma, right? That the system sees these people as, less than or not worthy of treatment. And then our individual personal biases also influence the way that we interact with these patients, even in a healthcare setting. So people are dying. Why isn't substance use treatment the standard of medical care? So there's FDA-approved medications for opioid use disorder, alcohol use disorder. There's really exciting work happening in the stimulant space. We know what works. Why aren't we doing it? Why aren't we treating these patients? Why aren't more patients receiving care? And the answer is very complicated and very nuanced, but if you really want to drill it down, it's education. The workforce is not aware of what options are out there, and they're not aware of how to administer those options or how to direct patients to that treatment. It's the system. The current system is not set up to allow these patients to succeed in treatment and to go forward into their recovery. And then it's the stigma, right? It's that structural, that social stigma that kind of surrounds it all and just kind of leads to everybody, knowing that we should be doing something more, we should be treating these patients, we should be doing better, but just kind of like throwing your hands up in the air. You don't really know what to do, you don't really know how to make it better. How does stigma manifest in the healthcare setting? So we've talked a little bit about this already. We talked about kind of the general public's perceptions of people with addiction or who use drugs, but how does that translate and evolve in the healthcare setting? And it's very interesting. Generally, like so many studies have shown that healthcare professionals, clinical and otherwise, have a really negative attitude towards patients with substance use disorders. They're considered reckless, they're considered wasteful, they're patients that administrators don't want in their care settings. There's just super negative attitudes out there. And it's very self-perpetuating, right? So what we've seen, and we'll talk about this a little bit more going forward, is stigmatizing language in the medical record is just rampant. And it's stuff that a lot of people don't even think about, right? The words that we use to describe people, or the words that we use to describe their disease state, or the words that we use to describe the reason that they are appearing in our practice setting for treatment. And we can see that there's been studies that have been done that show that the more stigmatizing language is present in a medical record, the worse care patients receive. So their symptoms, the symptoms they report are minimized, their pain is not treated, and it just perpetuates distrust. It's like bi-directional mistrust, right? The clinical providers don't trust the patients, and then therefore the patients don't trust the providers, and it's this never-ending cycle of mistrust and poor communication that just again results in poor experiences for everybody. And then another piece that's really interesting, especially from my perspective at an academic medical center, is the kind of, again, circular logic of continuation of this information, right? So attending physicians are usually, more established in their practice. They've been using this language. They've been approaching these patients in certain ways for the entirety of their practice. And now they are charged with educating residents and medical students. They're in charge of teaching them how to chart. They're in charge of teaching them how to treat patients. And so it's just perpetuating, right? Those residents are exposed to that negative language and they don't even think about it. It's just the language that they use. And then those medical students are exposed to that language as well. And then as everyone cycles up in that process, as residents become attendings, as medical students become residents, it just keeps going. It's perpetuating. And there's little in place right now in the medical education system to disrupt that. Really quickly, we'll talk about the way that addiction stigma manifests in clinical practice, but it's also very well researched, very well documented. Discontinuation of life-saving liver transplant, denial of valve repair surgery for patients with endocarditis, reduced access to primary care and pharmaceuticals. That's very well researched. There's been some really exciting research around the pharmaceutical piece released recently. And then just again, stigma, prolonged hospitalizations, potential justice system involvement, especially for pregnant patients or patients whose needs aren't met in the hospital setting. If they do have to use substances in the hospital setting and then they become justice involved, again, it's just very self-perpetuating. So that's our second takeaway, is that social and structural stigma negatively influence the way that patients with any history of drug use or addiction access and experience healthcare delivery. And again, that's healthcare related to their substance use and otherwise. It's not just patients who are trying to receive treatment for their addiction. It's patients who are trying to receive just general primary care or acute care for other non-addiction issues. So we're going to talk about healthcare training. I'm going to go through this relatively quickly because I don't think too many folks here are in the academic setting. But again, it was just going to demonstrate how much stigma is out there and what our healthcare learners are learning about patients with substance use or patients who use drugs. So it starts before we even see patients, right? So the step one exam is the exam that medical students sit for before they start their clinical rotations. And in a study of the exam itself and of the preparation materials, any question related to addiction or substance use described those patients, those hypothetical patients, with really negative terms: abuser, addict, alcoholic. They were portrayed as irresponsible and negligent, aggressive, uncooperative, verbally abusive. So this is the way that our healthcare education system is teaching medical students to think about patients with substance use. So it's not surprising then that they go into the practice setting and this is the context under which they are told to think about patients who use drugs. Do words matter? The answer is yes. We've seen many, many times over and over, but this is one of the best articles out there that exposure to stigmatizing language in the note was associated with more negative attitudes toward the patient. So again, the more that these medical students, residents, and attendings and faculty members are seeing this negative terminology in the notes that they're reading and previous notes for prior admissions, that influences the way that they deliver care for those patients moving forward. I'm going to go through the next slides really quickly, but generally the point is that we're not teaching medical trainees how to treat patients with substance use or who have addiction. The third bullet on here is the one that you want to look at. 62% of internal medicine residents at Mass General felt unprepared to treat addiction. And for those of you who don't know, Mass General is sort of like the gold standard of addiction treatment. So internal medicine residents at Mass General don't feel prepared. Residents at all of the other hospitals in the country also don't feel prepared. So then they go into practice not knowing how to treat patients. And then it continues into practice of almost 300 inpatient and outpatient general internists. Only 20% felt that they could actually screen and treat patients with substance use disorder. When I give this talk in person, I ask everybody to raise their hand and tell me if you would feel comfortable doing it. And usually it lines up with these statistics as well. And then one final point, a lot of what we've been talking about is medical students and residents, but it applies to all of our interprofessional healthcare providers. Generally across the board, nurse practitioners, nurses, PAs, dietitians, pharmacists, all generally had a negative attitude toward patients with substance use disorder. So it's a rampant issue across the interprofessional spectrum. So what do we do about it, right? What's the solution here? And I'm going to give you a handful of tips and some resources, and then happy to connect with anybody who needs kind of specific advice after the session as well. This is really exciting. In early summer, so back in June, Dell Medical School and Shatterproof co-hosted the Stigma of Addiction Summit and convened a working group of addiction treatment professionals and stigma reduction professionals across the country, like the best of the best, the cream of the crop. We convened these folks and had quite a few really in-depth working sessions to develop a healthcare stigma reduction intervention best practice guideline. I will stick the link to that in the chat right now, but you can also use that QR code. I think it's 2 pages and just a little bit more, but basically it's essentially a checklist of what your stigma reduction intervention should include, what it should consider, and what should not be in there, what should not be included. And it can absolutely kind of be translated or whatever, turned on its side to develop sort of metrics to monitor whatever intervention that you do choose to implement in your practice setting over time. The biggest takeaways from this guide are these 4 things. So use person-first recovery centered language. We talked about that a little bit already. Incorporate voices of people with lived experience. And this needs to be done meaningfully. And we'll talk about that in a minute. Deploy stigma awareness and reduction trainings, and then identify and eliminate structural barriers. So there's 2 pages of things to think about on that document, but this is kind of the big key points distilled down into some categories. Use appropriate language. There are, I almost said hundreds, I don't know if that's true. There are tens of language guides out there. This is the one that we use in our program. I know that Bewell, Texas has a similar one as well. There's a ton out there. Google it. I'll send you this one if you want it. There's tons out there. And just really start being aware of the language that you're using, both verbally when you're talking to patients, verbally when you're talking to your colleagues, and in the written record as well, in the chart. Stigma reduction trainings. Again, there's a handful of these out there. This one is one that we developed at Dell Medical School. It's called Reset Reducing Stigma Education Tools. It's at resetstigma.org, or you can use that QR code. This training, it's again specific to opioid use disorder, but it's very transferable to other uses. It's free and freely available. Anyone can use it. It does include continuing education credit for physicians, nurses, pharmacists, and social workers, and it's pretty brief. It's 2 20-ish minute modules that include videos, interactive activities. It's not just a PowerPoint with voiceover, and it really allows the users to learn how to identify and address stigma and how to change their own behaviors. There's one really fun activity at the end of the second module, which actually asks you to basically write an H&P for a patient and to not use any stigmatizing language. There are more out there. This is an abbreviated list. I'm sure there are plenty that I have not included here. But again, this is, I don't expect you to take this information away, but this is just to demonstrate that there's options out there, right? If you or your institution wants to implement a stigma reduction campaign or intervention, there's resources out there to use. Give it a Google, give it a PubMed search, see what you can find, reach out to me, I'll help connect you with whatever is helpful. And then use all of that, right, to identify and reduce structural barriers. So that's policies or institutional actions that restrict the success, basically, of patients receiving treatment for their addiction. Some of the ones that we see most commonly, at least in the hospital setting, is not starting or discontinuing treatment for addiction while patients are hospitalized for other acute medical conditions. Formulary restrictions. There's multiple FDA-approved medications for the treatment of various substance use disorders, but they are often not included on formulary, so they're very expensive and unattainable for patients. Care coordination. Patients may be treated in the hospital setting, but they are just discharged with no coordinated outpatient care. And then a big misunderstanding of the regulatory environment. A good example of that is no one understands the X waiver or what it's for, or when providers can and cannot administer, prescribe, and order buprenorphine. If you need help doing that piece, that's what Shout Texas is designed to do. Shout Texas is support hospital opioid use disorder treatment. We developed and implemented a novel model for treating opioid use disorder, but it's expanded to all use disorders in the hospital setting. And we are dedicated to now expanding and disseminating that model to all of the hospitals in Texas. That's what we're working on. So that's our final takeaway, and I'll leave all three of them up here. Is the last one is non-stigmatizing language, patient stories, and voices of people with lived experience, stigma awareness trainings, and eliminating structural barriers will increase individual and institutional ability to treat these patients and to reduce the stigma that these patients experience in your institutions or your practice settings. And I think I'm like exactly on time, so I don't know how much time we'll have for questions, but happy to take any of those.
Thank you, Alanna. Yeah, you can go on and stop your screen share. We saw some comments earlier too about some of the reasons for potential underreporting. So thank you, Bea and Kristen, for sharing that as well. Questions from the audience?
I just have a quick comment. Thank you, Alanna. That was fabulous. Like, gives us so much to think about. On the discontinuing treatment side, you made me recall that something really unfortunate where we were working with a local county jail. This is in another state, in a rural area, and there was a lot of stigma around methadone. And so when people would come in, they wouldn't be permitted to continue their methadone. But unfortunately, one of those people that was incarcerated was a pregnant woman, and she miscarried. And her child died, and it was just very tragic, but it was all around this mindset about just discontinuing treatment and not seeing all the ethical concerns there at a systems level. So I just want to thank you for bringing that back around to us of how important it is to think about continuing treatment.
Absolutely. A lot of that goes back to individual and institutional policies around, what risk is and is not acceptable. But a lot of that also goes back to, again, that misunderstanding of what the regulatory environment is. And at least in the hospital setting, which is what I'm most knowledgeable about and will speak to, is it is generally not understood that if a patient is already currently on a home dose of buprenorphine or methadone for their opioid use disorder, if they present to the hospital for any issue other than opioid use disorder, anyone with prescribing privileges in the hospital can continue to administer that medication at their home dose after confirming that home dose with the outpatient provider while that patient is admitted. But that's just really common confusion around the regulatory environment, like who can and cannot order and administer and prescribe these medications for opioid use disorder or alcohol use disorder.
And I should mention on that note, there was, I guess, kind of a silver lining in the end. Since speaking of regulation, the opioid treatment program that was treating her was happy to come in and provide her medication. And eventually they did work out that arrangement where they would come in whenever one of their patients was incarcerated and provide the medication so they could continue. But sometimes there are those kind of creative cross systems collaborations where you can resolve those barriers.
Alanna, I have a quick question.
Yes,
How are the language standards maintained? Are they included in the peer review or chart reviews? How are they sort of promoting that through some type of accountability?
That's an excellent question. At least at our hospital, we have not found a way to do this at scale. Again, it's hard to query the medical records. It's a lot of resource bandwidth required to review medical records. But what we have done is we have started to make it part of a specific resident rotation, not necessarily the treatment of opioid or substance use disorder, but generally removing all non-patient first language that is stigmatizing from charting. And so we have faculty members who specifically are, equipped to teach and guide our residents in language that promotes health equity, which at our institution does include language around patients who use drugs. And then it's just a lot of grassroots, I guess. It's counting on the residents to then kind of re-educate their attendings when they're in the situation where they're around other residents or attendings that are using stigmatizing language, or empowering, junior faculty to re-educate senior faculty, and just kind of providing that positive opportunity to change the way that you practice medicine. And there is an activity in our reset modules that kind of mirrors that. So it helps coach the users of the module in what language to use when talking to a colleague about changing the way that they use language or the way that they saw language in a medical record.
Thank you.
Alanna, that's a really terrific presentation you gave us, and I'm sure others have this question as well. We will be sharing these slides after this session because there are so many resources in there. And actually, this is really pertinent to the case we'll be discussing today. Before we get to that, I do have a few program announcements from Bewell, Texas. Carly, if you wouldn't mind sharing those slides. So Bewell, Texas is a welcoming environment with caring professionals ready to help people start or continue their journey to recovery. Bewell, Texas is committed to expanding equitable access to compassionate, evidence-based treatment and care for SUD throughout Texas. Next slide. The Bewell, Texas Clinic provides high-quality treatment for addiction and mental health well-being, including low-pay insurance and no-pay options. So to learn more, just visit bewelltexasclinic.org. Next slide. So here's some exciting news. We're launching a public safety solutions for SUD ECHO. That first inaugural session is going to be on Thursday, September 8th at 11 a.m. We hope to see you there. This program is open to public safety professionals, including law enforcement officials, fire and EMS personnel, community corrections staff, and others to assist them in responding to community members with substance use disorder. We will include a link to register for the entire series in the chat in just a few moments, and please do share this with your public safety colleagues. Next slide. Next month on this ECHO series, we'll be talking about the relationship between research and addiction policies. So we hope to see you there. Again, if you've registered for one of these sessions, you've registered for the full series. So we hope to see you at future sessions. And that's all I have. Thank you, Carly. All right, Daniel, I believe you have our case presentation for the day and have some co-hosting privileges. When you have a moment, please take us through this brief case, and then we'll open up the room for conversation.
All right, perfect. Thank you so much, everybody. Alanna, you were hitting pretty close to home on the slides about preparation and training of medical professionals. You brought back a lot of memories and just reminded me a lot of my prior experience. All right, now, what can you all see right now?
We see your slide view, so not your slideshow.
Okay, let's do this. Slideshow. All right, how about now? Is that a little bit better?
Yep, that looks
Okay,
good.
perfect.
Thank you.
Just sort of telegraphing ahead here, I will ask folks to make some comments in the chat bar here when we get here in a little bit here. So just be aware of that. All right, so this is case presentation. That's me. I have no conflicts of interest, and I've been encouraged to keep this brief. So I'm going to do my best here. Here's the background. So we have a teenage person between the ages of 14 and 17. The history is they're sneaking out of the house a couple times a week, spend time with their partner, kind of like a young love type situation. Occasionally they'll dabble a little bit with marijuana or alcohol, nothing really to excess. However, the evening prior to this particular patient's presentation, they tried an unknown pharmaceutical pill together, nothing else, right? So within about 20 minutes of taking that pill, the patient becomes unresponsive. The partner calls EMS. EMS comes and the patient is breathing very slowly with shallow respirations. They give them naloxone and they respond temporarily, right? So they're transported to the emergency department. They end up being intubated. They're admitted to the ICU for several days. What did we find? Not a whole lot. Labs were basically negative. The urine drug screen, which is an aminoassay test, didn't show anything. There was no alcohol in the patient's system. The serum toxicology screen, which where I practice, it's got in white, looks mainly for Tylenol and aspirin, was negative. So the patient spends a couple days in the ICU. As they come to, they're able to remember pretty much most of the evening prior to taking the substance, deny any history of sexual assault. There was no concern for that. Psychiatric history is pretty bland, to be honest with you, aside from sort of teenage depressed mood here and there. Essentially, they were diagnosed with an intentional overdose attempt, and the patient denied this adamantly. Regardless, the treatment team spoke with the patient's parent. They ended up getting transferred to a psychiatric facility for further assessment, stabilization, and that's where I'm at. Okay, so if you would in the chat bar, what do you think happened? Why did the patient present this way? What do you think about the overall presentation? And as you're doing that, also think about, what didn't happen here. I'll give you just a couple of seconds here to do that. Okay, and as you folks are putting some stuff in the chat bar here, and I apologize, I cannot see that. I'm afraid to click around. I don't want to mess this up here. So what is this picture on here? This is called the Swiss cheese model of mishaps. This is something we used in the Air Force. The idea is when you have a near miss or you have a fatal outcome or a sentinel event, usually there's multiple checkpoints along the way that had there been a systemic level intervention or some sort of well-designed barrier that you wouldn't get to this point, right? So how does that apply here? All right, so what happened? In this case, we don't know. However, knowing the high prevalence of fentanyl and the pharmaceutical, the illicit drug supply in the street, more than likely this patient took basically a fentanyl pill, overdosed, and came in as a result of that overdose, right? Fortunately, they were able to get all the way through treatment at the medical center, multiple assessments, laboratory evaluations, so on and so forth, without being diagnosed with what had actually happened, right? So what did we miss out on? We missed out on the opportunity to provide education to the patient and their parents, education surrounding, the dangers associated with drug use, the prevalence of pharmaceuticals that are counterfeit, also possible interventions, giving Narcan, that sort of thing, right? How could this be prevented at a system-wide level? Well, again, I think there's multiple sort of checkpoints, if you will, that if you think about it, we can design some processes, implement some policies that could potentially prevent this from happening. It's like somebody's unmuted there. And anyway, so starting all the way at the beginning, right? So at our institution, somebody comes in, they're altered mental status, they're sedated, we get a drug screen, right? Well, our drug screen is not very comprehensive. Unfortunately, not a lot of folks know that, right? So maybe just broadening that out to look for the common things that are used, right? Fentanyl, GHB, ketamine, all those kind of things, right? That would be a first step. I think that would catch a lot. Absent that, one level down, if we had some sort of language in the standard urine drug screen order, so the one that we have right now, that again is not very comprehensive, just to say, hey, you know what, there are potentially a lot of false negatives here. It's not going to test for XYZ. That would be pretty helpful. Of course, staff education would be helpful as well too. Again, this patient in particular met with multiple different treatment providers, and so far as I could tell, it didn't seem anybody got closer to the actual reason for presentation, right? And stigma, right? So it's prevalent. I think it looks different in different settings. I will say that in my experience as a psychiatrist in healthcare, I see it most commonly in two sort of different flavors. So one is, of course, the drug use is a moral feeling or a criminal problem, right? Somebody who doesn't want help, they're just sort of beyond saving, that sort of thing, right? And the other thing that I frequently see, and I don't know how to explain this, is that a patient will present with pretty rock solid history of substance use. Maybe they've shown up to the emergency department multiple times intoxicated. Maybe their urine drug screen, going back a couple times, always shows cocaine or something like that. But pretty definitive evidence of chronic substance use. They receive a psychiatric diagnosis other than a substance use disorder. Oftentimes they're diagnosed with schizophrenia in the setting of chronic stimulant use or bipolar disorder or something like that. And then the treatment offered is strictly for that psychiatric condition. And absent sort of recognizing that they, or at least briefly charting that they use drugs on a chronic basis, that's where it stops, right? And so that stigma takes what should be a substance use problem, transforms it into a psychiatric problem, and just offers treatment for that. All right. Okay, so just briefly here, the opioids in red, these are the ones that come up on most urine drug screens, the immunoassay. This is what's done commonly initially. And of course, that's not really what's on the street right now. Most of what's being abused, so far as I understand, is fentanyl containing counterfeit pharmaceuticals, right? If you look at use data, again, this is the SAMHSA data from a couple of years ago. We have 10 million people with opioid use disorder. 90% of those are not using heroin. What are they using? They're using what they think is hydrocodone or oxycodone or something like that, right? And that's exactly what these pills are going to be marketed as. Again, if you look at overdose data going back, again, it's a couple years old, but you can see that yellow line there, that's fentanyl, right? So that's really driving the trend there. All right, and here's a little picture of what they look like, typically referred to as blues, but counterfeit oxycodone containing fentanyl. So please, if you have any questions, go ahead and speak up.
Thank you, Dr. Levin, for the presentation. And you can go on and unshare those slides and open up the room. Thank you. And I will repeat that question for the full group. I see we've had some interesting conversation in the chat here. Great question. I missed that from you, Sean, about trainings for the child welfare system. And B, thank you so much for the response to it over in the chat. But thank you for the presentation, Dr. Lavin. Any questions from the audience?
I've got a quick question for you, Dr. Levin. When you talk about the scenario of a substance use condition being misdiagnosed as a mental health condition, and part of that having to do with perhaps the stigma factor, which is maybe a more comfort in that territory, and part of it perhaps related to education and knowledge. When you have a hammer, you look for a nail. If you're comfortable in psychiatric diagnosis, are you looking for mental health, and are you not comfortable looking for substance use? When you think about the proportion of those two things, need for education or the stigma-based judgment of patient, how do you see those two, or what's your ratio from your experience in terms of that misdiagnosis?
That's a great question. I think they both have a part to play. Just being, the product of the current medical education system, training under folks who have trained, years ago, sometimes many years ago. I think there's a significant amount of bias. So typically what I've experienced is, both the substance use disorder and the, what we think is a psychiatric condition will be recognized. There's a treatment offered for the psychiatric condition in the form of medications, therapy, so on and so forth. For the substance use component, it's recognized in that they will document it and they will say something to the effect of, I counsel the patient not to use illegal drugs, and that'll be the end of it. So I think there is a recognition there. There's just lack of a desire to treat it. And there's really no sort of systemic drivers to change that pattern. So that's kind of what I've noticed.
Great question, Matt. Others in the audience? Yeah, Leslie, I'll prompt you if you wouldn't mind to unmute and share your question.
Yeah, since we have you here, Dr. Levin, I would really love to see, do you have any specific trainings that you've used in mind that you felt have been really helpful, or any ways that things that maybe you've put into practice or play that you really believe has helped to make a change, especially related to stigma?
So I'll preface this by saying I'm relatively new to the system. We have a number of initiatives that are specifically aimed at increasing recognition and diagnosis of opioid use disorder. So I've done a number of lectures involving that, classically focusing on the local face of opioid use disorder, which is often iatrogenic in nature, and folks becoming dependent and misusing or overusing medications we're prescribing them. That's sort of been the main push. There are certainly room for other approaches here, but that's where we're at right now.
I can jump in and add some, sorry, Andrea. One of the things that we have seen be exceptionally helpful or productive, at least in the hospital setting, is peer recovery support specialists or peer recovery support in general. One, that's an excellent resource for patients as they are hospitalized. But in addition to that, and maybe from a systems perspective, definitely more important, is the peer recovery specialists often function as culture brokers, They kind of bridge the gap between patients and the care teams. They help the care teams understand the struggles that the patients are dealing with, in addition to their acute medical issues, their issues outside of the hospital at home. And they help sort of bridge that gap between patients and the providers. The other thing we've done in our setting is have those peer recovery support workers come in and deliver didactics to our residents and talks to our med students to just kind of talk about their experiences as a person who uses drugs, trying to access care in the healthcare setting. So again, it's using the voices of people who've survived the system, essentially, who've made it through the system. It's always easier and probably higher yield to have someone with lived experience tell those stories than someone like me, telling a story about somebody else, essentially. So we've found a lot of benefit and high yield from that. And I think there are some recovery support organizations represented on this call today. So if anyone doesn't know how to organize that in their hospital setting, I would say probably just do a Google for recovery organizations in your area, and I'm sure you can find something.
Any of those organizations present want to chime in though with some feedback?
I will. So I am 100% on board with that, and think that should just become at some point the new norm, like across the state, right? But I think at least in our area too, knowing that stigma and stereotypes and all that is an ongoing thing that we converse around. What would be some strategies that you might recommend on what's the entry point? My first thought is the social workers, and that's being that part of my history anyway. So I guess I'm a little biased for that type of a mentality or a worker. But other than that, like what would be some strategies to be able to engage with that system? We've got one medical system here. They've essentially kind of consumed all of Abilene. It's Hendrick Medical Center. And so there's a mentality that goes with that. And so how do what would be entry points to make change?
Thank you, Sean. Appreciate the feedback. And I don't want it to be lost to Dr. Wu. Looks like you shared a toolkit up here earlier in the chat, focusing on supporting pregnant and parenting people who use drugs. Looks like the toolkit and a webinar both being shared. Thanks for the support. Other questions or feedback for Dr. Levin about this larger scenario, this larger situation in place?
Hi, this is Kathy Hudgens. I have a question about the culture outside of the hospital and some of the factors that may be influencing some of the stigma and perspectives. I'm not sure where your facility is located, but even if it's community level, if it could be political, and what are the other drivers that you think should be addressed in order to lift that sort of perspective?
Great question, Kathy. So, I think it's probably a little of both. I practice in Temple, Texas, Bell County, kind of a little bit north of Austin. It's a fairly conservative area. I think so if we look at prevalence, the prevalence of opioid use disorder versus the actual rate of recognition and diagnosis, those are two different things here, right? And I think that because the face of it looks, honestly, like it should look, which is most people are not using heroin, people don't recognize that. And because we are a county that does not collect data on overdoses as far as the type, it's very difficult to sort of highlight these local anecdotal cases where you have, the end product of fentanyl in the drug supply, right, which can be overdose, right? So even though it's happening here, it's not recognized. And oftentimes it's that fatal outcome, which really catches people's eye and it leads to change and so on and so forth. So I think that's part of it. That aside, I think the institutional culture here classically has not, they're much less likely to view substance use as a medical condition as opposed to something else, right? And that's kind of borne out. We have met with different departments, for example, saying, hey, if somebody comes in and they have access to opioids, would you consider, discharging with a prescription for Narcan, right? And the response was, absolutely not, because they would fear that this would be promoting substance use and it might make it onto like a TikTok trend or something like that. So, that's just one example, but I think as a system, again, there's definitely some bias there that makes it difficult to think outside of the box. And even when we recognize it, to say, hey, this is the actual problem. Let's treat this, you know. Does that answer your question, Kathy?
And I see in the chat, Tempest, there's an offer of some resources there. I don't know if you want to speak a little bit about Homeward Bound. I want to make sure, Dr. Lavin, you see that in the chat, and we'll try to match you up as needed after the session. I do want to call attention, Sean, you mentioned a question, I think, to the larger learning community here in the chat. Any thoughts on this? Are there other entry points into a medical system other than social workers that would be recommended for peer recovery workers? Let's open that up to the room. Thoughts for Sean? Alanna, for those not looking in the chat, would you mind unmuting and sharing your thoughts?
Yeah, so my comment that I entered already was that at an individual patient level, I think, Sean, you're correct that social workers are probably the highest yield. They have kind of that better patient interface dynamic, and oftentimes they're more keyed in to the resources in the community. Other options as well could be community health workers or EMS. That's one thing that we have seen a lot of success with in Austin is we have a community health paramedic who will actually go out and do buprenorphine dosing in the field for patients, but he is really skilled in connecting those patients with recovery organizations. And then the comment that I was typing that I didn't get a chance to enter before I took myself off of mute was that if you're talking about how can RCOs be involved in the system in a more meaningful way, the process there is getting RCOs in the room with administrators, whether that's in the hospital administrators, outpatient administrators, whomever, is to get those RCO leadership folks in the room with administrators to sell, for lack of a better word, the importance of recovery support, whether that's through contracting with those organizations or direct hire of recovery support folks. It's not as, I don't think it's common at all in Texas, but in California, peer recovery is reimbursable by their Medi-Cal program. It's becoming more and more common to see those direct hires in healthcare settings. So, I mean, Texas has a long way to go before we're going to be anywhere close to California. But that's, I mean, it's not something that, you can just plug in and turn on tomorrow, right? But it's getting in the room with those administrators and trying to sell, quote unquote, the importance of RCOs and recovery support folks. And then chasing down grant dollars, which is so annoying and frustrating. But there are some, like I know FOR actually just released an RFP for some funding opportunities for community-based organizations to meaningfully impact rates of opioid overdose, I believe.
Thank you so much, Alanna. I appreciate you unmuting and sharing all of that. Well, we're getting to the end of the hour. I do want to thank Dr. Wu also has put in kind of bringing us full circle from what Alanna brought up in her presentation, and Adrian also shared afterwards some just further evidence of the importance of this kind of connected care. Dr. Wu pointing to another effect of stigma on delaying prenatal care. At this point, I do want to turn things over to our lead expert for today. Matt, would you share some of the key points made from today's conversation?
Sure. Thank you, Andrea. And thank you all for the dialogue conversation and for the presentations. I think that Dr. Levin helped to reinforce a through line from Alanna Boulton's presentation related to how there's this huge impact of stigma and its impact on our care system that's both broader culture as well as among providers, and much of that having to do with these sets of assumptions and a lack of knowledge. We're talking about education. Some of the core solutions that Alanna described, person first language, focusing on our language, persons, individuals with, rather than diagnostic definitions of people, getting the voice of lived experience into the environment, both of you talked about the importance of that, some stigma awareness trainings that we shared with you, some opportunities, and changes of policies and practices and procedures. I think the Dr. Levin's metaphor or vision of the Swiss cheese, holes in the safety net, however you want to envision that idea, speaks to the need for equality by design. How do we design a system that doesn't have those holes in it, that recognizes that substance use is not a moral or a criminal condition, and that notion of lived experience at the table that allows us to personalize the substance use experience, and therefore make some systemic changes to our policies and practices so that we can provide care as needed to folks with substance use conditions. Thank you.
Terrific wrap up. Thank you so much, Matt. And thank you, Alanna, for your presentation, and Dr. Lavin for sharing the case with us. And especially thank all of you for joining us today. I love what's happening over in the chat. We're hearing a lot of great feedback from today's session. Again, as a reminder to earn CME and for a chance to win that Walmart gift card, please do complete that post-session survey that Echo IT shared earlier in the chat. And if you'd like to present a case at a future session, we encourage you to do so. Just email bewelltx@uthscsa.edu. And we look forward to seeing you at our next session on Thursday, September 22nd. Have a great rest of your day and a wonderful long weekend. Bye, everyone.